So everyone's promised they'll be here, so we'll have the whole gamut of panelists. So the what we're going to have here is yeah, नहीं जा रहा आगे. Yeah, Kuresh sir, Nanashri, Nirmal sir. You need one more chair. So, well, no financial interest. So I have to acknowledge two young doctors who helped out with this presentation. And what we are actually going to do here is we're going to present real life scenarios which we all encounter every day. And the goal is to discuss the best way to communicate and counsel the patients. So what's important is you want to have an open-ended discussion. How you're going to encourage critical thinking, empathy towards the patient, and more importantly, ethical conduct. Professor Nirmal sir, please. So we have a fantastic panel. Dr. Kuresh. So the first and only father and son AIOS president, son duo as AIOS president, and a sense of humor par excellence. Welcome, sir. Then we have Dr. Ardiyat, sir. Needs no introduction. I'm going to just tell you one least known fact.
The slides are not changing.
हाँ, तो ये आगे नहीं जा रहा.
You don't know what he has got. As a schoolboy.
आगे नहीं जा रहा.
जत रहा है
नहीं वहाँ नहीं जा रहा. अच्छा अब आया. ये तो लेट जा रहा है. वहाँ नहीं आना देखो.
करना फिर से इस वाले पे देखता हूँ. प्लाज्मा प्लेट आ रहा है ना. अब देना प्लाज्मा पे.
नहीं
फ्रीज हो गया है.
वहीं फ्रोजन है.
एक बार एल्जीमाइज है ना.
उस तरफ से खेलो.
कोई नहीं चल
एक ही है.
चल नहीं दोनों एक ही है सेम है.
So the least known fact about Dr. Ravindran, can anyone guess? He plays hockey. He used to play hockey, and he's played hockey for the Tamil Nadu University and has represented them. He's also the opening batsman of the Arvind group of hospitals. He was among the first batch of PGs from Arvind. Thank you. So sir used to play back. Then Dr. Professor Nirmal Frederick, he's a wellness enthusiast, a marathoner, a cyclist, a financial and career advisor, and he also represents patients and doctors in state legal service authorities. That all of us know. Then Dr. Ramesh, a doting father and grandfather. Varshini is here, one of my favorite people. He used to play Ashe in the leagues of legends. That made him ambidextrous. Nanashri, well, she's a fantastic baker. She makes fantastic brownies, and cheese pakoras, but that's once in a few years. Another hockey player, Sangeet, used to play right and in front. He's been my roommate. He's been my Ofthal and guru. When I first joined as PG, I was sharing the same flat with him. And fantastic videos. He gets an award every video session. Surprisingly, he's not there this time, Sangeet. You took them all away last time. Then Professor Vijay Shankar, one of my best buddies, fantastic dancer. His father was one of the James Bond of Tamil Nadu cinema, and he's taken on the charisma and from him. And I'm the most boring of them all. So let's start with, we all get patients in our outpatient, and when you have a patient with cataract, what do you tell the patient whom you're advising a cataract surgery? Professor Nirmal, we'll start with you. So what all do you tell them?
Yeah. Thanks, Vinit. Thanks for having me here. And so I generally, when I see the patient, the optoms have already explained the vision and the difficulty. So I get to know the basic history first and the vision-related aspects. So I explore more about the patient's present requirements and complaints, match up with them, and if it is matching that, it is not amenable for glass correction, I tell them you have a cataract and that needs to be, I don't use the word operated, so we'll try the other methods, so tell them that a spectacle may correct, but it may not solve all your problems, and then advise cataract surgery. So that's the last result.
So when you tell them you have to have a cataract surgery, do you just tell them cataract, or do you go deeper into it?
Oh, okay. Let me come with this.
So I'm a patient. So are you going to tell me just cataract, or are you going to tell me also about the lens, about the complication?
I first tell them about the need for cataract surgery.
Okay.
And then explore the option based on their requirements.
Okay.
So I'll also open up here. We have a study called patient-reported experience measures going on in our hospital.
Okay.
So we track all the patient-related complaints first, and then offer them solutions based on those complaints.
Okay, that's interesting. So they give you the complaints before what they are looking for, you already get to know.
Their requirement. So
okay. Vijay, you want to add anything?
Yeah. Thank you. Yes, Vinit. Usually when my optom comes to me saying that the patient's vision is down and there is a cataract, patient immediately wants to find out what the cataract is. So I explain to them what a cataract is and tell them that that there is denaturation of the lens protein, and also it is more common in older people, and it is nothing to worry about. 99.9% the surgery goes on very, very well. And also I tell them that there are various lens options. I discuss everything in the first go and tell them that these are the things which we do, and then I leave it to them after that.
Oh. So you want to add?
Yeah, I don't do this. When a patient comes with the cataract, there are two types. One is the patient already knows he's got a cataract, because in our type of practice.
So we can't hear.
So your mic is.
So there are two types of patients. One who has come, usually they come for a second opinion. So they know they've got a cataract from somebody, and they're good enough to tell you that they've got a cataract.
Yes.
So those are tackled differently from a virgin cataract who doesn't know he's got a cataract. He's come for spectacle checkup, and we find a cataract. So then what I normally tell them is that you've got a cataract, then watch their reaction. Sometimes they are so frightened about the thing. Doctor, does it have to be operated? So I tell them, no, you can take your time. There's no rush. You can plan about, Can I wait 6 months? Can I finish my this and can I finish my daughter's wedding or whatever? So usually you can tell them that because it's, so I tell them, so there's no point in discussing lens implants with them when they're not keen at that time. While if a
Correct.
patient has gone to somebody else, has got a cataract diagnosis, still comes for a second, they're keen for surgery. That is the time that you can discuss lens options.
Yes. Adia, sir?
So normally I start off telling them with what is wrong in their eye, especially if your lenses, whatever has happened to the lens. I try to give them some description, and then I also tell them that the only option now available is surgery, and by doing that surgery, he is going to see much better. And I also
Yes,
discourage them against postponing the surgery, as it is probably the chances of developing complication, all of that is much higher.
Yes.
So whenever I feel the patient needs surgery, I try to convince the patient to get it done
So
at
you'll
the
take the
earliest.
decision for that.
I try to get it done at the earliest.
Yes, sir.
Yeah.
Ramesh, sir?
My experience is very similar to Dr. Quresh. So more than half the patients, they come to me saying they want to have the surgery done. So it becomes very simple. The others, they are divided into two halves. One half, they don't know they have a cataract. They don't improve beyond, let us say, 612 or 69, and they're not going to be happy. And for them, we will give glasses and tell them you have a cataract. It won't give you complete vision. Whenever you want better vision than this, you please come back. We will do surgery for you.
Yeah. Yes, sir.
No, just want to add. So in the early days when we were under Dr. V, he'll say that you got cataract and he'll say that you go and get admitted. He'll not say anything more. Because they also want somebody to make the decision for them.
Yes, sir.
And it's very difficult for them to make the decision. If I make the decision for them, it's easy for them to accept. So, you have to look at the patient's
Yes.
psyche and then
So you need
also
to
have
take
do
each
them.
patient
But
as
in
it
recent
comes.
years, the profile has changed. They don't believe me at all, like they used to 5 years ago. So now I stop telling them. I tell them it's your wish. When you want better vision, you please come.
Come back.
And
Just one thing I'll
gently
add on.
pass on and give them a pair of glasses.
Yes.
So that is how it was pre-COVID, sir. I'll tell them, they'll believe me, and they'll ask me when to have it done.
Yes.
But today, there's not like that. The trust has become a little less.
Yes, Vijay.
Yeah, one thing I'd like to add on. In spite of these high-profile patients, so much of Google search happening, patients are very unaware that a lens exchange happens in a cataract surgery. When you tell them that you have to insert a lens, they are very surprised. Doctor, you have to put in another new lens? That's their initial reaction. Then you have to talk about the other lenses.
Yeah.
So it's still prevalent till today.
So what we can tell them is, you have a cataract. So they'll ask you that, is it an emergency? You say no, you can plan it as per your need. And there are certain patients where we have to take a call for them, which is perfectly fine. And you tell them, no, if I was in your case, I would do the surgery. Whatever vision is lost because of cataract is the vision which will come back. And I also tell them that 99.9% I will place a lens in the first sitting most of the time. But in case I feel the support is not good, I may not, in which case then we will need a second surgery. I haven't seen patients run away because I've said that, but it makes me less stressful that in case I haven't been able to place a lens for whatever reason, I'm comfortable that I have told them in advance.
So
Anything
for
to add?
me, Vineet,
Yes.
most of the things that I tell a cataract patient is what is not liked by the anterior segment surgeons.
Huh.
The patients generally come for screening of their retina to me, and if I find some retinal diseases, I do advise them against multifocal IOLs, against silicone lenses, against the iris claw lenses. So I think that is the thing I generally tell them.
Dhanashri, you want to add?
Same thing. I generally.
You don't get cataracts.
Yeah, I don't get clean cataracts. I get all complicated cataracts. And for me, the decision is not whether the cataract surgery is mandatory for them, but it is whether it is mandatory for me, because I need to see the retina clearly. So that is the way I decide. But of course, the decision is left to the patient when they want to do it. So I don't pressurize them, and I give them time to get used to the idea of getting the cataract surgery done,
Okay.
unless it's a very bad cataract.
So then they've decided and they said, okay, I've come for cataract surgery. Now what do you tell them about intraocular lenses? Vijay, you'll want to take that first?
Yeah. When a patient comes, as I told you, the first thing we have to tell them is, what I do is, in my practice, a lot of patients are quite surprised when you tell them you have to remove the lens and put in a new lens. Now, they immediately ask, is the lens required? Then I have to explain the whole process to them. Then next we go to the type of lenses which are available. A lot of people in Chennai, I mean, many of them, the kind of people, the profiles I handle, they like to be glass-free, basically. I don't start off with glass-free at all. I first talk only about monofocal lenses first. First I talk about monofocal.
So you tell
and then,
them you
yeah,
need a lens.
You need a lens
and
first.
There are different
I will
types
screen
of-
you. I will do all your tests and see whether you're suitable for what kind of lens. Extremely important. And which lens. And I always tell the patient if they, if they try to talk too much, I tell them, I am the doctor. I will decide what is good for you.
Best for you.
What is the
Yes. Anybody wants to add on that, sir?
I give them the example of a restaurant, and when you go to the restaurant, you are the expert because you have sampled foods there.
Yes.
So if you want kali dal or yellow dal, it's your choice.
Yes.
Because you're the expert. But you come to me here, I am the expert. So I will counsel you, I will find out your needs, whether you're playing golf, whether you're watching TV, what are you doing. And then I will discuss with you what is the best possible lens for that. I only tell them that there are basically two types of lenses, monofocal and non-monofocal or multifocal. And all the others are cousins from the mother's side or father's side.
Yes. That was
And,
the
yeah,
next
so
question.
it gives
yes,
them,
sir.
it gives them a little bit of leeway, but they leave it to me. Yeah.
So if a patient says he doesn't want, yes, sir, sorry.
No. So we give them like a questionnaire.
Okay.
What are the activities they normally do?
Yes,
so
sir.
which will capture whether it is near vision or distant vision or intermediate vision, where they work on computer or they spend time on mobile or they watch TV or they play. So that based on that and then based on the biometry, then the counselor will decide or say for or against.
Okay.
If it's for a multifocal, then probably or a toric, then they come back to the doctor to discuss it further.
Then what do you tell them, sir? So that's the next question, that if you have a multifocal or a trifocal or EDOF, then what do you tell them?
Yeah. So if they are fit enough for a toric, then that advice goes in that way. If they are fit for a multifocal, where the astigmatism, all of that is low, and their near vision activity is more, so then we tell them these are all the options they can choose.
Okay.
So
So do you tell them about the halos, the glare?
we tell them that
Yeah.
part, but it is usually manageable. So depending upon if they are a driver, then they say these lenses will not be suitable for you. If you are not doing the night driving, then
These are better.
Yeah. So.
Ramesh, sir?
I also tell the patient, we'll take some measurements and find out which lens is best for your eye. And quite a few of them are quite sure they want it covered by the insurance or they want to pay a particular amount. So the choice is easy for them and they make a choice. When they want us to choose, I don't do multifocals at all. I only do monofocals, spherical and toric.
Okay.
And,
And why don't you do multifocals?
It's a long topic. Do you understand how diffractive optics works? Because
In
I'm
short.
not able to understand how diffractive optics works, so I'm not doing it. Anyway, so for them, we will do first eye for distance and second eye for reading. So I do monovision with about 1.25, 1.5 for 90% of my patients, and majority of them never wear glasses. About a third will wear glasses part of the time or full time. It doesn't matter.
Okay.
And they are used to it because they are referred by some other patient who has had it done in my clinic. So I get this smaller group who are used to
By
monovision.
mouth reference.
So now we have a non-diffractive presbyopic lenses also.
For patients who
The
have
patient doesn't
retinal-
understand the optics.
The
For
audio
patients
didn't
who
come.
have retina problem, like if they have a mild diabetic retinopathy or they have mild epiretinal membrane, they also ask you whether they can go ahead with multifocal or these kind of premium lenses. But I advise them against these lenses because I tell them that you are not the correct good candidate to have these lenses, because to have these lenses you must have a very clean and good normal retina with normal function. Because otherwise they will not get the entire potential of that lens. So they may end up with further vision problems or these halos, etc., that they talk about. So for patients with retinal problems, avoid multifocals and other premium lenses.
For patients with with the retina problems, I generally, who have to undergo the retinal surgery later or some other treatment, they will come to me which IOL should I go in for, though I'm not an expert in these. But then I tell them, you just go for the least expensive IOL because your main thing will be depending on your retinal function. So you should save your money for the retina surgery at least. Don't, don't punish me for that.
So the next question which...
The other corollary is, I now have patients who have completed about 20 years of a multifocal in the eye, the old multifocal.
Yes, sir.
And now they're developing macular degeneration just because they're aging.
Yes.
And they're quite happy because they need only +2 or +3 to see.
Add.
In spite of the multifocal, because otherwise you would have to give them an LVA type of thing if there was monofocal. Yeah. So I tell them that you're lucky that you had a multifocal put in.
Yes. So I tell all of them that 90% is the maximum amount of light that will focus at one point, 10% is out of focus. So you will have some amount of halo and glare. So if you want very crystal vision, a monofocal or a monofocal plus is a better option with I do a mini mono vision.
Vineet, I have a question for the panel. The choice of IOL in pediatric age group if the patient is having bilateral cataract. So will you place a multifocal IOL or a monofocal IOL?
No, only monofocal, because so recently also operated on a 15-year-old girl. So we explained clearly about the monofocal requirement and the future growth. So we never know about the growth of the eye post-surgery, so it's always safe to have monofocal in those, time-tested one. And second, a legal issue also, their parents have to decide on their behalf. So it's a very tricky question. So after 4 years, 5 years, the child can come as adult and question you, why didn't you use this or why did you use this? So we don't have any answers for it.
So the next question which all of us get, will you be doing robotic or laser surgery? So the audio didn't play. Actually, we had a patient when they come and he was asking, are you going to do robotic or laser surgery?
Yeah.
Then what do you say?
Yeah. A lot of patients ask for these robotic surgeries. I mean, it's become a very fashionable word now. Now, when a patient comes to me asking about this robotic laser surgery, I always tell them that yes, we have this facility available, but there is no great advantage compared to the normal cataract surgery we do. There is no added advantage, but well, if you have the money, go ahead.
So it's not robotic, it's a laser. It does part of your surgeries and it can double the cost. As of now, there's no additional benefit, but if you want, you can definitely go ahead and...
if they like to see two machines, why not?
So Vineet, what I tell them is they will ask me what is the difference between the two. So I just tell them you draw your line with your hand, but if you take a scale and draw a line, the difference, this is the only difference, otherwise the things remain the same. Or if you want to draw a circle with your hand, and if you want to draw it, definitely with good surgeons, the circles they will be able to draw with the hand also. But if you are drawing with a compass, you'll get an exact circle. And that is the difference. Otherwise, the results are almost the same. That is what I tell them.
I tell them that even femto is flex. Femto laser assisted.
Cataract.
So I stress on the A part, that the machine is only assisting you. Then I describe vividly what will happen to them, that they'll be in one room, they'll have a laser done, then a small putty will be put on the eye, they'll be wheeled into another room where the surgeon is waiting to do the phaco, which he would have done in single room.
Yes.
The point is you're paying for the first machine in the first room extra, but the surgeon is still going to do what he would have done if he had not visited the first room.
Sir, sometimes the patient after the surgery asks for the robo, sir.
Yeah.
Where the robo is? Where is the robo, doctor? We didn't see it.
So I'm sure all of you would be getting these same questions. If you have any...
Vijay, you should come dressed as a robot then.
We'll get somebody ready.
So this was also a question put in the ESCRS panel discussion to a group of ophthalmologists about whether you would get a femto versus a manual. And I think the whole 99.5% said that they would just go ahead with the phaco. So I tell them that if you don't have any added benefit, there are very few cases where we may actually have a benefit like a subluxated, but in others it's too expensive, you're not getting any added benefit. So I would rather just do the phaco now. If in future, if the money comes down or we see the added advantage, then definitely we are all up to taking the technology.
Yes, yes, Vinit. I mean, like even within Aravind, we have several hospitals.
Yes, sir.
So we bought initially in 4 of our hospitals.
Okay, sir.
Then after that, all the newer, bigger hospitals, we never bought them.
Okay, sir.
Yeah. The second thing is we offer it only for the patients who ask for it.
Okay.
So there are a lot of patients who specifically come for that. Then we provide that service for them. But we ourselves don't promote it.
Don't promote.
Yeah.
Yeah. So unless a patient comes and asks, we don't even want to advise them.
So we, the patient should have the choice. So
That's why
also
we
keep
have it.
it.
Absolutely. So then this is another thing which is very common. Patient comes saying he has been advised cataract elsewhere. You examine him and find minimal or no cataract. How do you counsel them without undermining the previous surgeon? What do you tell the patient? Adya, sir?
Yeah. See, I mean, very often it's being done as a refractive lens exchange. Then I try to explain them the principle. So by getting, so you don't have a cataract, but the surgery is being advised because you have a refractive error, so that you can be.
He doesn't have a refractive error.
Yeah.
Sir.
Then it's a difficult question.
Yeah.
So that's what I tell them. If you are willing to continue with the glasses, you can go along.
Go ahead.
Maybe come and see us once in a year or so.
Okay.
But if you are don't want to wear the glasses, then probably you can accept that.
Yeah.
You can undergo the surgery.
Nirmal, sir?
Yeah, very often we come across this third, fourth, fifth opinions. So we asked them why this question arose. What was the real intention of coming for a fourth opinion or fifth opinion? So basically, when you ask the assistant, he will say that we were advised, we quoted some high amount, we are not sure, or some optical person sent. So these kind of clues we can get. So we tell them that at present, you with all your requirements, you can manage with glasses. There may be few retinal issues which needs to be sorted out, so we can further get your other assessment done and try to help you. So cataract surgery is not an emergency, but you have to be on frequent follow-up. Once you feel that your vision is not enough to carry out your regular activities, at that point in time, you can come for a surgery.
Yeah. So I tell them, yeah, you do have some amount of cataract, but your vision is still good. So as long as it's not troubling you, you can wait. Once you feel that there's a further fall in vision, then we can go ahead and plan the cataract surgery. You can come anytime or come and show me in 1 year.
So I undermine myself.
Huh.
So I just say, by the amount of cataract that you have, I feel that you don't need a surgery. But definitely the other surgeon he's a great surgeon, and he can operate you at this level also. But and if you want, yeah. So that is how I counsel them. And generally they take the advice that they feel that they don't need the surgery, and they just.
Yeah. So good way to say is, yeah, you have. So you're not even undermining the next surgeon, but say your vision is good, so we can wait. Please come back whenever you have a vision fall. Dhanushri, you're very quiet.
No, I generally tell them that this cataract is a process, is not just a one-time diagnosis, and the cataract will continue to progress. And there can be a difference of opinion among the specialists. So we can wait for some time. If your vision is good and if your daily life is not being hampered, you can wait. And once the cataract progresses, then we can take you up for surgery.
Yeah.
So
So any one of you from the audience want to say something, please do tell us. Next question.
One interesting thing is, if you, in Tamil Nadu, in the class 10 textbooks for the students, under the refractive error, the refractive lens exchange is offered. Cataract surgery is offered as a treatment, one of the treatment.
Really?
It is there.
Yeah.
Oh, I didn't know that. So this is another thing which all of us get. What do you do when a patient starts bad-mouthing or complaining, about another ophthalmologist? Kuresh, sir?
Yeah, I put my hand up like a traffic policeman and tell them, stop. I wasn't there. Suppose he's describing the surgery.
Yes.
He's had a surgery and he's had a bad experience. So I tell him, look, I wasn't there in the theater. Every surgeon tries his best. What you're telling me may or may not have happened. I wasn't
Perfect.
there.
Yes, sir.
So looking at your eye, I don't know what the surgeon did, what went wrong, if at all. You come to me to know how to become better. Let's take the discussion from there. So I put my hand, every time he starts to do this, I put my hand, then he gets it.
That's a nice way. That's a nice way. So you have to professionally and ethically navigate this conversation to a ground and say that every doctor does his best. Why would he want to harm you? He's been doing what he thinks is
So
the
I
best
think
for
to
him.
quiet that patient,
you.
I just like tell them whatever the doctor has done is best, and you're speaking these things in front of me. I think it's just fate that what has happened, and maybe if I would have done it, you would be seeing the same things for me to another doctor.
Oh, 100%, it's a chain reaction.
Yes.
Yeah. I think the best way is a traffic signal, a traffic sign. And also tell him that he's your friend, the other doctor.
Yeah,
Anyone, sir, you want to add something?
I want to add. So I tell them that the surgeons are very egoistic people.
You
And
do?
actually, yeah, because they feel much worse if the surgery fails. So if your surgery fails, I feel even much worse than you. And no surgeon wants their surgery to fail. So they are trying their best to give you the best outcome. If anything is happening, it is possibly out of their control, and that is why it has happened. So it's not it should not be blamed for the surgeon. So that is how I tell them.
Varshini, you're allowed to add whenever you want to. Anybody, please. Venkatesh sir, you can please tell if you have anything. So,
I think this is a audience interactive session.
Yes, you
so,
can.
Yeah, you can have. If you have any problem, you can always
Dr.
ask.
Lal,
otherwise.
please, sir, anything, anytime. So it's good to professionally and ethically navigate this conversation. Don't be the judge. Don't judge the patient. Don't judge the doctor as such. Tell them that everybody is doing it for your good. Otherwise, he wouldn't want to become a doctor. Why would he? Which doctor wants to do harm to you? He's taken. I tell them that why would he want to do any harm to you? He's done his best. Probably if that can happen to anyone's hand. And like Dr. Muscati sir said, we'll take it from here because we don't know what happened on the table. So
there are a few things I tell Vinith. I mean, one is I tell them this can happen in certain percentage of cases, like 1, 2, 3%. And again, this incidence, if we are not sure what type of cataract you had. If you had a bad cataract, it can be as high as 8 or 10%. The second thing I also tell them is in that we at least use 10, 15 type of medicine consumables. So many things are being used, and all of that can contribute to that, not just the doctor. So it's very difficult to say who's at fault.
What has caused
So what has caused all of that? So, but we'll tell them that we'll try and we'll make it, make sure that you get back your vision or it's possible.
We'll help you from here.
Yeah.
Yes, sir. So this was just again a patient with significant astigmatism. You recommend a toric intraocular lens. What do you tell them? Why are you putting a toric? And if he says, I can't afford it, then what? How do you go about it? Ramesh sir?
I usually tell them that the eye should be like a ball, while if you have a toric power, it becomes more oval. It's no longer a circular part. So the regular lens will not give you such clear vision. So we have a rule of thumb. If you've got like around 1 cylinder or 2 cylinder, I'll say like it'll be 2 cylinder. I'll say it'll be 20% better if you have a toric lens. And if he has about a 1 cylinder, he will need a T3, for example. I'll say you'll see 10% better, which will work out to be about 1.5 lines.
A toric is not covered under insurance or most insurances.
My package is cost of lens plus the surgery, but doesn't cover the multifocal.
So he comes back and says that this one.
So if your center can absorb the cost, you can put a less expensive toric lens for the same cost as your imported.
Do you talk to
AIOS5.
them about the advantage of a toric? So what I tell them is that you have an astigmatism and putting a lens is very close to the nodal point of your eye. So you will have, so they look at me nodal point, but nobody will ask you what the nodal point is. But they realize that it's very close to, if you have, I tell them if you have one refractive point, it's just right behind the lens. So your vision will obviously be a little more crystal. I also tell them that in early postoperative period, it can move. And if it moves, I'll need to take you back to the operation theater and redial it. And obviously it comes at a cost. So you need to warn them that if it happens, I will take you back to the operation theater and do it. And if they tell me that I don't have the money to do it, then I tell them it's okay to go in with a normal lens, but you'll need glasses. You'll need the astigmatism correction in your glasses and you'll see only clearly. The next question they generally will ask you is that means I don't need glasses after a toric. Then you have to tell them no, you still need a glass, but your vision without glasses will be more crystal. That's how I try to convince them with it.
Yeah, that's superb. Now, many of our patients, many of my patients, we have very good Indian toric lenses now available, which when we tell the patient, and not everybody can afford a high-end lens, basically. When you tell them, they somehow get the money ready and get it done because they want clear vision. They don't want to wear a -2, 2.5 outside in glasses, basically. That's one point you should tell the patient.
Yes, good point. Yeah. So this patient comes, you have done surgery, he comes back to your OPD, there is a residual astigmatism. This is, say, a glass appointment 3 weeks later, and you put it on your eye trace or any of your multiple calculators, and rotation will help. Now what do you tell the patient? Kuresh sir?
Yeah, that unfortunately everything went perfectly, but your lens seems to have moved. Something is going on, but at no extra cost, we'll fix it, we'll make it right.
Okay.
So there's no extra cost involved. We'll make it right, the simple small rotation that we have to do.
So we don't have that in our institute. We can't do that. So that's why I warned them prior. So Dr. Badrinath used to tell us that never make anything free. If you make it free, it's especially something like this, it's acceptance of guilt. That it was something which you did wrong, and we haven't done anything wrong.
No,
so
Vinit, it's like a LASIK with an enhancement later. you do a LASIK and sometimes there is a residual error, and almost every center will fix it for free. So it's similar concept. You've done something, little tilt, little this is required, you do it for free. In private practice.
Private you can, we can't.
I also feel that I think it's better to admit sometimes. I remember one case, like I was doing a dislocated IOL, and when I put in I took out the eye lens and I had to do an exchange. So I thought there is still a good amount of capsule left. So I thought I'll just put it in the sulcus. That will be the best for the patient. And I put it in the sulcus, but next day that lens was also down. So the best thing I did was at that time was like I admitted. I told him I thought that this will be the best for you. And I did it likewise, but unfortunately that lens has also gone down. So we will have to do it again, and I won't definitely I won't charge you, but we have to take out this lens and have to put an anterior chamber lens or whatever scleral fixated lens. And we did it like that, and patient was quite willing to undergo that.
Yeah.
Otherwise, if you try to keep hiding things.
Yeah, never hide. That's very important. Tell the patient the truth. So what I do is like when I finish my toric case, I go and tell them I've done the toric, I've put the lens exactly in position, and pre-operatively I tell them that it's only in the early post-operative period that it moves. And if it moves, I need to take you back. So I tell them once the surgery is over, I tell the attendant I have put the lens in the place. Hopefully it stays there. And if it's moved, then I tell them we put it on place, but in your case it's moved. Next question is, you'll rotate it? I said, yes. What if it moves again? Then I said, if it moves again, we'll have to redo it. But it's very, very rare. It generally occurs in the only once, and generally occurs only in the early post-operative period. So I tell them that and then go ahead. And we have to charge. So we don't have the option of waiving off the charge unless Dr. Sudhir, for enhancements, do you charge? Sudhir, do we charge for enhancements, LASIK? Yeah, at SI? No, no. You do? I can't hear you. Come to the mic.
He doesn't want to answer.
He doesn't want to.
These cases,
Yeah, it's on.
see, in these cases, we generally charge for the cost of the material, not for the service.
No, for the LASIK enhancement.
Classic enhancements, very rarely we do. So basically, if a patient comes after 1 year or 2 years, it's not the mistake of us, it's the regression which has occurred.
Early post-op?
Early post-op, we don't do it.
You?
We don't do.
You don't charge?
We don't do it.
Don't do,
They don't
okay.
get only complicated.
Yeah.
So you have an intumescent white cataract.
There's one small point I want to add,
Yeah.
since Sudhir is there, Dr. Sudhir is there. I had a patient who came, I discussed this patient details. We had a refractive surprise. He was a post-LASIK patient, came for a cataract, was hell-bent on a EDOF lens. We put the lens for him, we had a refractive surprise -2. So guy was very upset. He was a VIP patient. He said, sir, this is not acceptable and all that. I said, wait for 3 months. We'll do a top-on LASIK. We will try to do for you. After 3 months, we noticed power came to 1.5. Then he said, sir, 3 more months, it came to -1. Now he is happy. We left it like that.
Good.
So time is the best healer for some cases.
Like the question, whatever you post, we have discussed, it's all about two values. One is about transparency. Other one is about informed decision making or informed consenting. So one, it's always better that any procedure you do it as a package. So whatever the complication, anything you have to do, probably you cover that from that cost. And if you don't want to cover it, then it has to be part of the consenting process. The informed consent, there the patient has to be told that there can be a lens rotation, and if it happens, whenever it happens, probably additional
So you also charge, you're like us, no sir?
No, we don't charge for that, but if we have like a PPC and we expect a nucleus drop, we tell the patient, you may have an anterior
Second
vitrectomy,
surgery.
even vitrectomy, then there's an additional cost of
No, for a
5,000
toric
rupees.
rotational, do you charge?
We don't charge.
You don't charge.
We don't charge, but we also have some of our hospitals got a practice of seeing the patient within 1 hour and try to fix it immediately also on the
Yeah,
same day.
it generally occurs in the first few hours, yes.
So they have a practice of seeing them before sending them home. If there is any rotation, they'll do it. Or the next day, always they check whether the rotation is correct or not. So they try to do it at the earliest so that it is easier also.
Yeah, that's a... And for LASIK enhancement, sir, do you charge?
No, as I have not seen anybody being done.
Okay.
And maybe one of our
Yes, sir.
hospitals, they may do
Yes,
it.
That
sir.
brings another.
Okay.
Yes, sir.
Vineet, waiting is the best option.
Yeah. So that's a different story. It may be, I've had around 2, and I generally wait till GA, till the final checkup, and then decide. I don't do early. I believe that let the wound heal, and then let me see what the final is before I do. I think I've done 2. One I did after 1 year. This was, it had addition, but it moved. So it really varies. It really varies.
So another point I want to add.
Yeah.
Like the moment we say that we have to rotate it and this will be the charges, there is a high chance that the patient will go for a second opinion.
Yes.
So if he goes for second opinion, then the dissatisfaction level automatically goes on increasing. Even if you rotate it and bring it back.
Yes.
So if he has gone for a second opinion, he will, throughout his life, he will say that something had gone wrong, so my vision is less. Even
So-
if he sees 6/6.
So the good idea, that's why here is when you're advising a toric, tell them that this is a possibility. So I tell them my counseling starts when I'm advising a toric.
Yes, sir.
That I will place it in position. I finish my surgery, I tell the attendant I have placed it in position. Hopefully it stays there. Then if it has moved, I tell them it has moved a little. And these calculations tell me that we need to redilate, you will get even better vision.
But is the patient told that there will be extra charges for the reading?
Yes, yes.
He will be told before.
Yes, yes.
To be
So we
very,
try
very
to
clear,
make it minimal.
if you are willing to tell the patient before surgery that you have a 1 in 20 chance or 1 in 100 chance of this problem, if the problem occurs, one more surgery will be needed, it will cost you so much money. This is part of the information, this we had to tell them before the first surgery itself. If you don't tell them, you add that cost to your primary surgery, because it's a rare thing, 1 in 20 or 1 in 100, and you can absorb the cost. If you don't tell them how much it is going to cost, you have to absorb it. Before the first surgery, if you tell them you may need and it will cost so much, you can ask them to pay for it.
Yeah. So this is another one. You have an intermittent white cataract with chances of flag sign. What do you tell the patient? Ramesh sir or Nirmal sir? You can take that.
Yeah, I tell them this is advanced cataract. So I'll ask the reasons why they waited for such a long time.
Okay.
And second, so that actually helps us to put the onus on the patient that it is a complication because of the late presentation. Second thing, the high risk of flag sign, but it will take all precautions to safeguard from, like usage of OVD and also other backup items. And there may be some additional charges for the backup items, or we may or may not be able to place the lens they want. So in that case, we'll have a backup lens also. And we'll try to do as much whatever possible for the patient to regain vision.
Yeah. So that sort of sums up the whole thing. You tell the patient that, yeah, we took I tell them your lens pressure is very high. As soon as I go and touch the capsule, it can split, in which case still most of the time I can put in a lens, but if I can't, then you'll need a second surgery or whatever. So that I tell them 99% you still have a chance that everything should be good in the first case. So you're doing surgery, you have an anterior capsular runoff. You have placed a single piece IOL in the bag. Do you inform the patient? What do you tell the patient? Ramesh sir?
I will not disturb the patient with these irrelevant facts.
You won't.
I will just treat them and take care of it. That's it.
Anybody else? Anything different? So I tell them that the front part of the capsule was a little weak, but we have placed the lens, everything looks good. We don't need to do anything. But if you have to place a 3-piece lens because your anterior capsule was completely gone, then what do you do? Ramesh sir? You have an EDOF. Now you have to put a monofocal lens, monofocal plus. And now you have shifted over to a 3-piece.
So the cost will change.
Yes.
And the patient will bill less. So all I will tell is your eye could not accept the lens that we planned for. We have put a different lens made by the same company of excellent quality. You will see well.
Same
That's
material.
It.
Same material
Yes,
also.
yes.
Anybody else? Anything different?
I will not charge less because patient will doubt me immediately and say that I put an inferior quality lens.
Anybody else? Sir? No?
Yeah. No.
I think you should charge more for the extra effort that you have put.
So charge for the surgery.
Yes. No, as
Please,
long as
doctor.
we
Yes,
don't
yes,
charge
come.
them
Please
extra
come.
for this, they won't mind.
Sir, I believe if we tell the patient about anterior capsule, flag sign, all of that, it will scare away the patient. Anyway, it is a white cataract, so most probably the reason why he prolonged surgery was he was scared. So instead of scaring him all the more, I'll just tell the patient that we'll try our best to put a lens, whatever fits well, and if that cannot be done in the first sitting, it can be done in the second sitting.
Beautiful.
That's one way, but it's always good to cover yourself and say that there is a chance. And it's a little more chance in yours, and 99% I'll still do it. But let me take the final decision on the table. So you say, I'm going to do the best for you. So I'll decide what I think is best for you on the table. So once you tell a patient that, he's willing to trust you to his
I would
life.
also add here that it's imperative we tell them all the facts first, maybe in a subtle way. A breaking bad news or a difficult news So there's a way of doing it. You can draw certain thing on the paper, show them videos. So visually you can explain and tell them, but you are in expert hand and we have a wonderful team with backup support. We'll take care of that. So that would be the best way rather than hiding certain things. Because after that, if something happens, patient has all the right that you're not being transparent. You, since you not told me the fact first, you tried to conceal the fact with us. So this is what happens in many times in the consent-related queries in the court. That doctor didn't tell us this, or the team didn't tell us this. So we should not leave room for this now.
So this is the next question. You have
Vineet, can I just add one more thing?
Yeah, yeah. Sure.
So I do exactly what you do. I don't try to scare the patient because a scared patient is a very difficult patient for us. They tend to have problems. So in this situation, no, I'll call the son or daughter or the attender and tell them there is some extra consideration. This is what you have. And in the consent form, there's a small box, special consideration. There is special consideration for this particular patient's surgery. It's not just a routine one. It will be left blank. So before surgery, we had to fill it up. Special consideration, risk of vaginal flax and risk of a PCR, risk that one more procedure has to be done. So in the special consideration, you will handwrite the special problem this particular patient has. And then the consent has to be explained to the attender. Anyway, they have to sign it. So legally, we have to inform them. It has to be documented in a special consideration box in your consent form. Normally, it will be left blank. There will be no special consideration.
So what about a posterior capsular rupture without vitreous loss? Do you inform?
Yeah, so this is where I get the relatives to praise me highly by telling them, you know what, it was so difficult. The capsule was so thin.
Yes.
It was so tough to put the lens, but anyway, we managed and everything has gone off very well.
Super.
So then you get a sort of pat on the back.
Yes.
Yeah.
So you have done a good job. Imagine if you have a PC rent and you've still placed, you haven't got vitreous loss, you've put a lens in the bag, you need to pat yourself. So tell them, yeah, it was a difficult surgery. The capsule support was weak, but we have managed to place a lens. Everything is good. So we just need to, but I'm informing you that this is, because if this patient goes to another of your colleague and they tell that there was some problem during surgery, didn't the original surgeon tell you? This patient will definitely come back and question you. You don't want that.
Yeah. It's always better to see these patients and the relatives together and explain them that everything went well even in spite of the problem.
Yes, sir.
And going back to that question about intumescent cataract, so so a lot of things have to be systematized in a place like ours. So we divide cases into 3 groups: normal, complex, high risk. So certain, like the intumescent lens will come under a complex.
Yes, sir.
And the appointment thing, they get it also mentioned that cataract surgery complex. We put it there. Or cataract surgery high risk. High risk in the sense they have subluxated cataract or post-VR cataract surgery cataract or an anophthalmos cataract or phacolytic glaucoma. Then the patients also know that it's a high risk. So they also understand what is high risk.
Do you charge them higher, sir?
Today we charge them higher because for the consumables they'll need.
Okay.
Additional consumables, the CTR. Or
not for the surgeon's skill.
Not for surgeon's skill.
So don't you think we should?
No. We are in the transition. So this is now the team is getting trained to getting accepted to that level of. So we also have to make sure that the advice part goes on well. So once we know that is set, then probably we need not charge for the consumables. We'll charge for the surgery.
Yes. So now you have a vit loss, you have done a vitrectomy. Now what? What do you tell the patient? Do you charge for the vitrectomy? What do you tell them? So, Kuresh sir?
So I don't have a vitreous surgeon with me. Also, I will just do whatever I can, do an anterior.
Anterior vitrectomy. You just have an anterior vitrectomy.
Yeah, I'll just do an anterior vit. I'll possibly not put a IOL.
No, you've put an IOL.
Oh,
you've done a vitrectomy, you've put an IOL.
I've done everything, so I'm good. So,
you've done a fantastic job.
So then I will definitely come out and tell them that there was this problem. Try as I might, I couldn't prevent the jelly of the back of the eye from coming forward. That's why the lens I had originally planned I have not put. I put a different lens.
No, you've put in a 3-piece. Or you put in a single piece.
No, single piece also I put.
Yeah, yeah.
I am fine. I am
Would you
phenomenal.
tell the patient?
I had no clue I was this good. But then if I've done that, then I tell them that I have managed. Yeah, but I've never managed so far until today.
So I would tell them, I'll ask the patient, you tried to make it more difficult by moving, but I still could manage all these things.
So, do you charge for the vitrectomy then? No.
No, I don't charge. I'm doing it myself. I don't charge. Yeah.
Okay.
So no, we'll charge if it is part of the consent form we have taken. We say that we may need this anterior vitrectomy.
So, but we don't know which patient, no? So, isn't
that
it
is-
one
that is where
consent form?
all these complex cases and high-risk cases.
No, it's a normal patient. But there
normal
were,
basis, then we will not charge.
no, but you didn't cause the rent. You didn't cause the vitreous to come in front.
But I haven't told the
Okay.
patient.
I think,
I haven't told
Dr.
the
Vinith, we are opening a Pandora's box here. A few issues here. One is the costing methodology, right? So if you have done something extra, use something extra consumables, and also use time and resources from our part, it is legally justified to charge the patient. Occasionally, as a charity, or if you know the patient, you can tell them that this is the cost that has happened. Since you can't afford, or we have not informed you in a better way, we are writing up the cost. I think, so this is what it's going to come in the near future. The costing of surgeries will be done in a different way, not as a package. So there are fixed costs, there are variable costs. This fixed cost is related to the infrastructure, the theater time, and all those things. And this variable cost depend on the surgeon's expertise, experience, the type of implant, and the variable consumables if you are using it. So even the insurance billing system will change in the near future. This is what associations are fighting for. And it's always better, like RDR sir said, so we have to improve the costing of our services.
Yes.
Leave alone the ethical part as a straightforward business and trading aspect. We need to charge our patient for the things we use, whether it's consumables or the time and expertise.
So, what about this? You have a nucleus drop intraoperatively. The patient now needs another surgery. What do you tell the patient? What do you tell the attendant?
No, y'all have just told me I'm so good that I don't draw.
So, but now
I am
you
now on a
couldn't help
different high
it.
only.
So, we are in that good. So, we had a drop.
So
Now, what do I tell you?
Occasionally you are bad.
You plebeian surgeons can answer this. No, but seriously speaking, of course, you tell them that this happened, that the lens fell, part of your lens has fallen in. It's beyond my capacity to fish it out. I would cause more problems. So we will call in an expert to help, or I will send you to the expert, depending on what the thing is. And if I call in an expert, he will charge. I will charge the patient extra also. Because we're telling them that it's not, in spite of our best efforts, and you come to Dr. Maskati, Dr. Vinith has just said he's the world's best surgeon. But this has still happened, imagine. So yes, charging is no question. You will charge extra for this.
Sir? RDR, sir?
Again, it's based on the consent. Without a consent, if the patient, it's a regular surgery happening, then we absorb the cost. But you'll always inform the patient.
Okay. So,
And again, we also learned from some of our peripheral centers. So when it happens, we tell them that, you go to the hospital, and then there they'll take care of you. They may not charge you all of that. But we also found some of them not coming to the hospital for getting the surgery done. So we also now make it a point to have a staff accompany them, take them to the hospital, get them admitted.
Okay.
To make sure that, even they have a serious sight-threatening complication, it's all about taking ownership.
Yes.
So I think we have to go beyond that. Even if you have to send to some other doctor, you don't have facility, sending to another doctor, maybe you have to call the doctor, tell them, fix an appointment, whom they should go and meet. All of that, if you can facilitate, then you can minimize a lot of problems. Yeah.
Yeah,
coming
so
out of
in
that.
our institute, we will probably charge, in the first surgery, you cut as much as you can, don't charge for phaco, don't charge for vitrectomy, just put the minimal consumable charges and tell them that a part of your lens has gone behind. I need my retina colleagues to help out to remove this. So once they see that their bill is not too much, most of them don't complain, and you say, I will fix the appointment, and they will see and help you. I have an in-house VR surgeon, so I don't have a problem
You have especially in the house only.
in the house. So say you have a patient with pseudo-exfoliation.
So Vinit, last
Yeah,
thing. What
we
the
are
last
coming to that. I'm coming to your nucleus drop. It's coming to you. You have another question on that, Sangeet. Pseudo-exfoliation, what do you counsel the patient? Anything special? Do you tell them about risk of zonular dialysis?
Yeah, so because it's fresh in the mind, just 2 weeks ago, I had an anesthetist who was my patient who had pseudo-exfoliation.
Okay.
So since she was intelligent enough, I spent time, chair time, explaining to her about pseudo-exfoliation and all the things that can happen, and told her that we'll see what we can do and we'll manage. And luckily, everything went off very well. So at the end of it, I told her we've done everything and that you will have no problem from now on. But important thing is increase chair time, and at whatever level of intelligence the patient is, come down to that level and explain about everything that can go wrong.
So I tell them you have a white deposit.
Consent again.
Yes, I tell them you have a white deposit. You have a risk of high pressure.
Yeah.
And you have a risk that your lens support would
on
be
table
weak.
and post-op. Two
Yes.
things. Yeah.
And you may need a CTR. I even tell them that. So you're doing surgery and you end up with having to put a CTR. Now what do you do? What do you tell the patient? Would you put in a three-piece? Would you put in a CTR?
If I need to put a CTR, I will note it down in the discharge summary, but I will not be telling the patient because they can't understand what a CTR is and the functions is.
So you don't charge for the CTR?
No, I
you
will not
absorb
charge.
the
It's
cost?
just a few hundred rupees. See, the costing, changing the cost is the number one reason for dissatisfaction. If I tell them it's going to cost so many thousand rupees, even if I charge 2,000 or 3,000 more, they won't be happy.
So that's for you can do it. In an institute like us,
In an
we
institute,
can't.
it's a problem. It's a policy. But I think unless we tell them before surgery that these extras will be charged, we should not charge them.
No, but
At
there are
least- at
certain
least for as a
patients you
private
find
practitioner.
out on the table. There's no phacodonesis.
So what happens is this is all rare. So I think of it as I add this cost onto my total package.
Okay.
So maybe my profitable level is 45,000 rupees for a procedure, and my complication rate is 1 in 1,000. It's going to cost me extra 1 lakh. I will divide that 1 lakh among those 2,000 patients. So it'll come to 500 rupees more per head or something like that. So I will not be charging per patient for the extra consumables. It will be part of the package.
Nirmal sir?
Yeah. So if I can read the questions right, on table,
Yes.
right? So, so it is an intraoperative problem. If I have already anticipated, the patient is aware of this, I put that in the consent. And this is, if this is unanticipated, I go on to place a CTR and tell them. So if I have not told them before, I may not charge for the consumable. But I have already told, and it is a high risk case, it will be charged. Maybe I will not charge for the surgical part, only for the CTR.
So what I do is I tell them that the zonules were weak. We needed to put an extra ring to support it. It will cost you a little extra. So I just tell them that. Most of them are saying, did the surgery go well? I say, yeah, the surgery went well. We put the lens and we have put the CTR. They have no problem paying. Most of them don't complain.
Vinit, I'd just like to add something here. I think we are all working in different setups.
Yeah, that's
And
why the
maybe
panel.
in an institution, all this is possible. But in a private practice, sometimes these things are not so possible. We have to be flexible sometimes. So we need to be flexible. In our
I
hospital, we just deal the cataract surgery as a contract between the patient and you. And we do whatever best can be done for the patient at the whatever cost we have promised to the patient.
That's it. Beautifully said.
At one point,
Yes, sir.
we just completed 10-year follow-up of patients who had pseudo-exfoliation. We did a study
Nothing
Yes, sir.
happened.
of patients of pseudo-exfoliation. These are all early pseudo-exfoliation. So where we have divided them to two groups. One group got the CTR, another group did not get a CTR. And the same, there are another two groups. One got single piece IOL, another three-piece IOL. We did not see any difference in the subluxation or rate.
In the centration.
Yeah. So of the 9,000 patients, there was only one drop of the whole lens IOL complex. Otherwise, it's very low. I mean, here pseudo-exfoliation, it's all about clinical examination. There are two things that will say that there is subluxation of the zonular weakness, which is, as you know now, the AC depth variation.
Yes.
Other one is the pupil not dilating. So these two are there, then we have to tell the patient the prognosis and additional costs involved.
Yes.
Otherwise, most of the patients, they do
Will
well.
take it. So a patient with a posterior polar cataract, Vijay, would you take this?
Yeah, when I see a patient in my OP with a posterior polar, I explain to them the type of the cataract. I tell them that first they have a cataract, and this is a different kind of a cataract where their lens support is weak.
Perfect.
So I always tell them that they may require an additional second surgeon with me,
Yes.
and for
So
the vitrectomy part.
You've done your surgery, you've put the IOL, you have cortex and epinucleus in the vitreous. What do you tell the patient? Do you tell them or you?
No, the patient themselves will say that they have floaters.
Okay.
So tell them that there's a small, I mean, it depends on the amount of epinucleus which is there in the vitreous. Usually only if there is a nucleus, I'm a little worried. Epinucleus, small amounts get absorbed. And if the amount,
Done.
the amount
Point.
is
So if you have a little bit of epinucleus
can leave it,
cortex, you just
It
tell the
gets
patient,
absorbed,
yeah, there is little bit, but it will generally absorb itself. But you have left the patient aphakic. Now how do you counsel the patient? What do you tell them? You can, Nirmal.
Yeah. So I tell them that the support is very weak and we couldn't place the lens. So once the main wound heals and the eye quietens, we'll review, do the appropriate investigation, and then plan for a second sitting with IOL placement.
Yeah.
Now, for the retina people, Dhanashri, you can take this. You referred a nucleus drop by an anterior segment colleague. As a VR surgeon, how do you handle the situation?
So you have to be transparent. You have to tell the patient that there is a nucleus drop, but this can be handled, quite. You are in expert hand, and it can be handled well. You need another surgery to remove the nucleus, and we can at the same time. Sometimes we can also fix intraocular lens, either a three-piece one in the sulcus or a scleral fixation lens. So we tell them that this is a complication, but it can be managed well, and the outcome can be quite good. So there is nothing to worry, and you just reassure the patient that this is just a temporary situation and it can be corrected well.
Do you complain against the anterior segment colleague?
No, never. Never.
One more
we
small
never
question
complain.
to you, doctor. What do you wish I had told my patient before I send them to you? I have a nucleus drop, I send them to you. What do you wish I had told them?
What do you wish? No, it is just that the patient should know that there is a nucleus drop, which is a complication of the surgery, and I don't think you need to go into nitty-gritty of what can be done, but you just tell them that okay, this will be handled by the retina surgeon, and they will remove the part of the nucleus because otherwise it can cause further complications, and it will be handled well. Eventually the outcome will be good. It is just that it is a little bit lengthened process, but eventually you will get the vision back. Yeah.
Sangeet, this is for you. Patient also has a giant retinal tear and retinal detachment. Obviously, the anterior segment surgeon has tried to fish.
Yeah. Yeah, still, I think I won't criticize the cataract surgeon, even at that moment, right? Pardon, sir? Yeah. So I think I'll start from the very beginning. What in our hospital, when a cataract surgeon is operating, has a nucleus drop, he tries to put in the lens himself, and he does not fish or nothing. We just do it, if possible, we just do it in the same sitting itself, the nucleus drop, and the patient is handled well. If the patient is referred by somebody, they have explained now. Now I think the referring ophthalmologists, they also know that the outcome is generally good. even if the nucleus drops, and if they don't handle the vitreous.
Yes.
So they don't, most of the ophthalmologists who refer them to me, they know that the patient will be taken care of. And, but certainly we do have situations when there has been fishing has been done and retinal detachment has happened. And at that time, I think I don't criticize the surgeon, but I generally inform that there has been some trouble in your eyes. And this generally happens in some patients, and we can still take care of your eyes, we can save your eye, and you
Yeah,
need
so
another surgery.
You cover the back of the anterior segment surgeon and say that there is an issue behind, but we will handle it, and you don't put the blame of the fishing on the anterior segment. Please, don't, please. So next question for both the retina. You have a post-op, first is for the anterior. You have a post-op endophthalmitis. How do you inform the patient as the operating surgeon? Ramesh sir, you would like to take that?
You had a very rare problem. You're having a severe reaction in the eye. I'll be giving an intravitreal injection now and send you to a VR surgeon who will take care of you. So this will be the gist of
How did the infection come?
There was no infection. The word infection is never used.
Yeah, so you
As
should
Ramesh
not
said
use the word
correctly,
infection at all.
Reaction, inflammation, this is what you had.
Yeah, reaction, inflammation,
And
swelling.
swelling, those are the words that you use. And we are taking care of it.
Okay. And retina people, you referred a post-op endophthalmitis as a VR surgeon. What do you counsel? How do you counsel the patient? What do you tell them?
So it is a tough situation, but of course we never blame the surgeon. We say that this is a
The surgeon
situation-
doesn't cause end-off.
Of course, yeah, but the patient thinks that the surgeon has done. So anyway, you have to manage the situation. We tell them that this is a situation which requires some urgent treatment, and if it is a mild endophthalmitis, it is good. They will be, cured with either injections or intraocular injections or eye drops. But for severe situations, they may require vitrectomy. So we tell them that we are trying our best to control the situation and control this reaction inside the eye. But they need some extra medications and extra surgery for that.
Okay.
Two words I will never use is, one is the infection and another one is the pus.
Is the?
Like pus inside the eye or infection, because these are totally layman words which are taken very negatively, and then the patient is really after the primary
surgeon,
doctor.
the primary surgeon and you. RDR sir, this is for you.
Yeah. So, I mean,
Cluster
the
endophthalmitis.
Correct. I mean, this I personally handle at least 3 or 4 episodes within Aravind. So, the first thing is when I see 1 or 2 patients, when you see the second patient, then you know it's a cluster. Then we have to call everybody who are operated by the particular surgeon or the particular operating room. Whatever the patient says, I'm good or whatever it is, we even call and tell them, you come by taxi, we'll pay for it. So we get everybody to see, make sure that the rest are all right, and then we try to understand what has really gone wrong. And then, when you're able to bring the patients early, and then management becomes much easier. When it is at the early stage of inflammation, then it becomes much easier. So, I mean, here, more than the patients, the patients' attenders, their sons and daughters, they are more important.
Yes.
They are the people whom you have to handle. And if you are able to take them into confidence, not just the patient, then probably you can avoid the media.
So what do you tell them to take them into confidence?
Confidence in the sense, one is that we'll be able to take care of them and get back the vision very often.
But if it's a fulminant, something like a pseudomonas, which
even pseudomonas, if you find them early, you can bring them back.
Yeah,
So
they are
only-
of a poor prognosis.
Yeah, only where you cannot give assurances when the infection is due to streptococcal infection. The streptococcal very rarely cluster. It is usually sporadic. Pseudomonas is common, and pseudomonas are usually amenable to some type of, and especially when we know it is hospital-based, then we use tazobactam straight away. We don't go to the regular antibiotics. So
The media has come to know about it.
Media, then, if the media comes to know about it, then we have to face. We have to, I mean, if you keep the patients on your side, then the media will not come inside.
Okay.
So the patients and
That's
the relatives,
important.
because
Most
we also
important.
have handled other cluster, cluster referred by other doctors, and we also make sure that that doctor sends one manager and one nurse along with the team, and they take care of their needs, and we take care of the medical needs.
Okay.
And we have tried, we make sure, even sometimes we plead with the media not to make it a big
Issue, yes.
at least one or two instances.
Yes, so you have to be nice to them.
That has to work, yeah.
Yeah, so it's important to be empathetic to the patient, tell them that, yeah, but we are all handling it together, and we'll do our best. In case the media comes, you need to tell them, see, this has happened, we are doing our best, and hopefully we should be able to control the whole thing.
We need one thing more about endophthalmitis. I generally tell them that this is your body has not accepted the lens as such, rather than explaining.
You put the blame on the lens.
Yeah, I'll put the blame on the lens. So I tell them I'll use some medicines as an injection, as a drops. If your body adapts to them and your lens gets accepted, it's fine. Otherwise, we may have to remove the lens also.
That's one way, probably, yes.
I'll just add few points, Vinith. We just had a discussion about the adverse reaction.
Yes, sir.
I just gave a talk on the medical legal aspects. A couple of things here, we have handled a few incidents and helped our colleagues. One important thing is breaking the bad news, particularly the cluster endophthalmitis. So we need to take not only the patients, the immediate relatives, and also the society. Right? So very often the problem is created by the immediate society or the community rather than the patient. So patient is in a different mode because he's got lost vision or going to lose vision. The second aspect is handling the media. So for that, we need to escalate the situation to the association or local prominent people. We need to take their help. So quite often we see that we can handle the media in a better way if we address them as a association representative instead of the doctor directly handling. Particularly for private doctors, if you are alone, always please take help before the situation escalates. Because if it is in the earlier phase, like RDR said, most of the media people are really helpful. So we can always appraise them in a private room, tell them this can happen, and as association representative or representative from the professional group, so we have faced this and this can happen to anyone. So the medical part of it, let the doctor take care. The negative aspect of handling the patients and the community, please help us to tell them in a better way, and that's how we handle the media. And we also take the police and the press people into confidence, it becomes easy. So only when it escalates into a newspaper or a 24/7 media blitzkrieg, it's difficult. So before that, it has to come to the association or the local crisis committee.
Yeah, that's important. You have to trust your association, whether it's your city or your state. Come to them and take their help when you are here. That's why those associations are made, right, sir?
Yeah, it's also important. What Nirmal said is very important. Handling media is very, very important because it's going to affect everybody's practice, not that particular doctor. The whole profession, because in the 2000 we had seen 1 or 2 incidents in Tamil Nadu, and where it got a wide publicity, and I can say that everybody's cataract surgery went down by 30%, not just the surgery, even the outpatient for everyone. So, it's not good for the whole, for the whole community.
Yes.
I think we have to take it as our problem. So,
and also now very important to involve the local authorities, particularly the joint directors and the deputy directors in the public health, because they are more worried about the negative implication in the media than caring for the patient or the vision part. So if we take them into confidence and get them into our side, it's easy to face the media or the public backlash.
Now, this is something we all get. Next question is, how do you handle an aggressive patient? You have patients who come into your OPD and you know the vibes are aggressive, he's out to get you.
One thing
Quresh,
is
sir,
never meet aggression with aggression. So that will create a lot of problems.
Yes.
So
See, the important thing here is that one single English language word called empathy. The patient has a problem, real or perceived, whatever it may be. But you meet it with empathy, you put your arm around his shoulder, preferably if it's a same-sex patient as you, and tell them that I can understand where you're coming from, and if I was in your place, I would be equally alarmed or I would be equally annoyed at what has happened. But sit down, let me explain to you what has happened or what you think has happened. This is how it has occurred, and you and I together will answer this and come to an acceptable conclusion.
Yes, sir.
So take him in first. Don't let him make halla gulla in your OPD outside, because he'll stir up the 10 patients who are there, for those who have 10 patients in the OPD.
No,
But so take him in immediately. Keep your other patient. Tell your other patient, excuse me. You know, if it's somebody in my room also, I'll tell him go out. Call this guy immediately and give him plenty of time. And then apologize profusely to the next patient whom you threw out. Yeah.
So like there was a patient who came, I did cataract surgery, came for glass appointment 66N6, and I told her I need to see you again in 6 months. Why? Why do you want to see me in 6 months? You finished the surgery, everything is good. So I said, you need to come for a routine check to see if everything is all right. What can go wrong? What did you do that can go wrong? So then you say, no, it's not that I did something wrong, but you send your car for service every 6 months, you don't mind paying for that. What's your, to check for yourself, you should invest in your health. Prevention is better. How do we handle patients who think they know more than us? Ramesh sir.
This is very tough. I think we should find out what Dr. Quresh, just find out why they came and what they want. And if possible, we should guide them to a place where they can get solutions.
You can go on, sir.
You see, many times you can make out a patient who has been a Google person, who has gone to Google and has got the information. So then I have a list of the 2 or 3 websites, like the AIO website and things like that. And I tell them, why don't you go to this website, you'll get authentic information over there, because you've heard it from...
So now they have Chat GPT.
Yeah.
They have DeepSeek.
Yeah.
And they say that this is what we got here.
Yeah.
See, whatever you advise, if you have asked the patient to go to this investigation, they've already done their search and come, most of them. And they tell you that, I've already searched, I just wanted to know what you're telling me.
Yeah. So you tell them you come to me because you feel that besides the information that you get, what to do with that information, we are expert at processing that and telling you what is good for you.
Yes, sir.
Chat GPT will tell what is good for everybody.
I think if a person has used ChatGPT and put the correct diagnosis and keywords, what ChatGPT says and what we advise will be the same. So ChatGPT is our friend. And often in tough situations, I tell them, you have nodular episcleritis, and I will and my nurse will just type it up for them and say, this is what ChatGPT says, these are the tests we will do for you. And Google AI and ChatGPT, if you show it to them, 90% of these questions are answered. And I ask them to take a photograph with their phone and go home and do these tests as advised by Google AI or ChatGPT. Otherwise, they'll be asking us 101 questions.
Dhanashri is going to talk.
So, see, the 2 things. One is that you have to listen to them patiently, never lose your cool with them. And sometimes it is good if the patient is already knows about the disease and other things. So you don't have to spend much time in explaining everything. And sometimes, like Dr. Ramesh sir said, I only tell them that go Google this and learn more about it, because we don't have so much time to sit and explain.
What
for half an
about
hour
the
for
paper
every
you
patient.
published?
Yeah, so we just published a paper about where we compared the human experts versus ChatGPT. So especially for cataract complication explanations, that what we are doing now. And so the similar prompts were given to ChatGPT and we got the answers. So what we found that the surgeons, the human surgeons were more specific and they gave more specific answers to the complications, and they were also more empathetic. So ChatGPT will give a very generalized question, and ChatGPT, the prompt has to be very, very specific. Then it will give you a little bit better answer. But definitely the human touch is much more important, because you are looking at the patient as a whole. I mean, you are looking at the body language of the patient, the vocal tone, the nuances, and the reaction you are seeing. So as human experts, you are obviously much better off in handling this situation.
Okay, we just have 5 minutes, so we are
I
just going
think
to.
it's very
rush.
beneficial in my practice that the patient comes informed of everything, that he has got the worst prognosis. So I don't
Yes.
have to take care, take care of those
Vijay,
problems.
you can take this.
Yeah,
How do you handle a VIP
just,
patient?
Just for the
Yes, sir.
last question.
Yes, sir.
I mean, it's also interesting. Now we are testing an AI solution. So that AI solution, for somebody who is coming, they are getting examined, everything. Then you ask the AI solution to counsel the patient. Even speaking Marathi or Punjabi, it will be able to counsel the patient, and the patient can ask any more questions. It will be able to answer everything to the patient. Wow. I think that is another possibility for patients like that.
Very good.
Yeah, Vijay, you can take this.
Yes. I mean, I handle quite a few VIP patients. The first thing for VIP patients is privacy. They love their privacy. They want to be left alone. They want time with their doctor. They want to spend time with their doctor. Most important thing about VIP patients, please treat them normally, give them time, explain everything to them, but please be firm. Because there are a lot of things which they want from you, which they extract from you. Be extremely cool with them. And there is something called as a VIP syndrome, which we sometimes sometimes we overdo for the patient. Please treat them very, very normally and tell them this is this. And yes, we have to take care of their privacy. It's very, very important. They want to be treated, they want everything to be under a secret. Make sure that everything is done well for them. But I remember I had one union minister. He was a 5-time union minister. We had a discussion in my room. He had some issues in the retina. He was insistent he wanted multifocal lenses. He's an MP now. He wanted multifocal lenses. He said, "Doctor, you should put only multifocal. I don't want to wear glasses in the Lok Sabha." I said, "No, sir, sorry. You have a problem in the retina. You cannot use these lenses. You'll have a problem." We had a fight. Half an hour, 40 minutes. Because of that, 2 VIP patients went away.
You lost your temper.
I lost my temper. I didn't lose my temper. No, 1 minute. I just told them in a nice way that I told them that we cannot do it. You can go to somebody else. That's what I told them.
Yes.
If you can call it losing temper. The patient relented, came back, had those lenses, and then I operated about 50 people through him.
From him, yes.
So nice.
Nirmal sir. Communication, counseling and consent for patients at high risk. So you have a patient who has a 30% ejection fraction, has a 660 vision. You don't know, he wants surgery. A patient's attendant comes and tells you, is it risky, will he survive? You take the call for me.
Okay. A couple of things here. So this CCC is my favorite acronym. So one is the ocular risk. Second one is the systemic risk. For the systemic risk, I use my anesthetist and physician to handle, but I list the high risk in my high risk consent. So that is the documentary part of it. But also spend considerable time on explaining both the high ocular risk and systemic risk to the patient as well as the attendant. And I also have this habit of recording this counseling session. So this, I categorize these patients as high risk. They go through high risk examination.
Video recording? Audio?
Both video.
Video.
Yes. So we have a recording facility in the counseling room. So we record this. So tell them first the ocular high risk and then the systemic high risk, and list all of them in the consent form and give a copy to them.
Okay.
For them to read and then come back. Once they come back, I'll read again and sign in front of them.
Okay.
So this
we
is
have
the legal
just
part.
2-3 minutes more.
Yeah.
Kuresh sir, communicate in case of a death on the table.
Yeah, so this is something that happened to me. I had a death on the table, but then patient was very bad risk. So we spent 1 hour, myself and my anesthetist, with the patient's 4 relatives and us, We were closeted for 1 hour explaining everything, including death on the table, because the patient was obese with a collagen disorder, diabetes, hypertension, thyroid, you name it. And he had corneal perforation, for which I was going to put an amniotic membrane under GA, both eyes, bilateral corneal perforations. So he died after the surgery. Means he came out of surgery, said hello to relatives, and then died while he was being wheeled out of the into the ward. But since we had communicated everything, relatives were absolutely okay. Important thing is don't get petrified of the cops, but call the cops in. In Mumbai, we have a Panchnama where 5 witnesses are called, and the cops take the statement at that time, and postmortem is mandatory. So I insisted on a postmortem. The cops were telling me if the relatives are happy, just give them the body and get a friendly family physician to certify heart attack. Don't show that a surgery also took place. The problem with that is those 4 relatives are cooperative. But the patient has got 27 other relatives right from Jumri Talaya to New Zealand to Timbuktu. They will emerge afterwards and eat your head. So best is to follow protocol as it is. And I insisted on a postmortem, sent my hospital manager with the police in the ambulance, in the hearse, to get the postmortem done. And then everything went off very smoothly after that. Yeah.
Okay, last question before, because it's time up. Just the last question. Patient's attendant is recording audio, video without permission. They come with their phone and you know they're fidgeting and they are recording. Do you allow?
I tell them it's against the law. What you're doing is against the law. It's proven. It has been adjudicated. So you can't do this. The problem is many times you don't know because their stuff is so powerful that you don't know. You just put the phone on the table and he's recording. You don't know. So then you can't do anything which you don't know. But if you can spot him from doing it, you need to tell him to leave.
Now, if they come and ask you, sir, can I record what you're telling me?
Absolutely no. I'll give you a printed summary of our conversation.
Okay, I think there are a lot more questions, but for paucity of time, we will stop. If you all have anything to say, any questions to ask?
One last question. Yes.
Is it a good practice to throw statistics at the patient? Like suppose you're dealing with a posterior polar cataract, the chance of a second surgery is less than 10%. Is it a good practice to throw such statistics which we can later on get back to you, saying that from where did you get the statistics? I have searched, it's not there.
Yeah, one you can use it for counseling, but not the exact data, right? You can use the data for counseling, that to tell the patient that there is a risk of this issue, so you can use that for counseling.
So I believe in Western countries, doctors are not allowed to quote statistics because patients then sometimes take them to court for that particular statement which you have made.
So good idea is to tell them that's a number, but every patient is different. So you may fall or you may not fall in that category, but there's a risk. That's it. So I say I don't give them a number, but I tell them that your risk is higher than a normal patient. Just that.
But some patients appreciate if you tell them the statistics, they appreciate that and they understand that it's the doctor is knowledgeable and they know the subject well. Yeah. So some of the educated patients, they are very impressed that you have told the entire rationale of the treatment along with the statistics. So there was 1 or 2 patients who really appreciated that I was giving them all the statistics. So
this last question,
depending on patient,
you
can decide.
Bad outcome surgery, how do you handle yourself?
Oh my God.
Dear sir, this is for you. You have to tell us.
I'll pass it on to anybody else.
Suresh sir?
How best to explain?
No, so the important thing is to be empathetic. Tell them whatever that you have tried your level best, but the blood just kept coming, or this is very, very rare thing which has happened. And I have patched the eye and have come out, but the chances don't look very good. Don't write it off, but say the chances don't look very good.
And you need help.
You need, yeah.
How do you handle yourself?
This is the difficult part.
Nothing.
Isn't this important?
Have a cup of tea, yeah.
This is so important that you need to take care of yourself at this point.
In 1983, Professor Fedorov came to Mumbai, and we had a seminar on intraocular lens implant. It was the early days. And he was asked the question that if you get suprachoroidal hemorrhage, what is your treatment in Russia for suprachoroidal hemorrhage? And without batting an eyelid, he said vodka. And then we asked him, very seriously, we were, do you inject it, IV? He says, no, I drink it. So, true story, true story.
So,
So
handle
Vinit,
yourself.
I'll double the dose. I'll just have two instead of one.
That's a joke. Doesn't mean you all do it.
The one point about this percentage. So before surgery, you have to say you have to talk as if it's 100%. Post surgery, you can give any kind of anything you want. 15% or 20% it may happen. But before surgery, I think you have to tell the patient he's got a chance of, which means like 100%. So that patient is going to get it. So, yeah, sure.
Sometimes they have some disproportionate things. Every patient is going to get this. You tell them that no, this is only 5% chance of developing RD or 10%.